Good morning. I'm Marlene Neville. I am a longtime, Gaspin board member and have the pleasure of introducing our first speaker today, Dr. Phil Ayers. He received his Bachelor of Science in Doctor of Pharmacy from the University of Mississippi. He's employed by the Mississippi Baptist Medical Center in Jackson, Mississippi. He's a clinical specialist in nutrition support and serves the Department of Pharmacy as Chief of Clinical Pharmacy Services. He's also a clinical associate professor with the School of Pharmacy for the University of Mississippi. And anyone who's been involved with Aspen for a period of time will recall that Phil was also a past president of Aspen. And he served as the chair of the Aspen Parenteral Nutrition Safety Committee, which we've gotten a lot of our parenteral nutrition safety guidelines from. He's a board certified nutrition support pharmacist and has been one since 1996. He's been the recipient of several Aspen Excellence Awards in nutrition support education and parenteral nutrition safety. And he has published and presented numerous topics dealing with parenteral nutrition safety, lipid injectable emulsions, fluid and electrolyte management, and acid-base disorders. He's a fellow of Aspen and has had numerous awards throughout a lot of the pharmacy and nutrition support organizations. And he is a wealth of knowledge. And with that, I would like to introduce our first speaker today, Phil. Thank you.
Thank you, Marlene. That was just a nice way of saying Phil's getting old. Okay. It's a pleasure to be with you today. I think this is the third time that I've spoken at Gaspin. So thank you to the board for the invitation. Really looking forward to this. And I want to thank you for all the work you do. Being a past Aspen president, I was on the board for 14 years. So I saw a lot of the work of state chapters. Let me tell you what, this is a stellar state chapter. I wish more and more were like this. And I think of all the people that have come through this chapter, they've taken on leadership roles in Aspen and more to come. So I'm looking at here, seeing some young folks in this audience, and I know there'll be many of you who will take on those leadership roles, not only in your state, but also on a national level too. So thank you again for allowing me to be here. So the topic's parental nutrition fundamentals, navigating the complexities. So we all know that parental nutrition is a high alert medication. It's unfortunate that even in my profession, some directors of pharmacy, others don't really consider it a medication, but it is a medication, one of the most complex medications that we utilize in patients. And so it really doesn't get the respect that it deserves. So through the work of Aspen, Marlene mentioned the PN Safety Committee. Many of you have seen publications that have come through that, really starting in the 1990s, but really, I guess from that PN Safety Committee, we first saw the guidelines and consensus recommendations developed, and then, guidelines related to lipids and filtering and photoprotection. Just a lot of things have come out of that PN Safety Committee. Now it's the PN Committee, no longer the Safety Committee. So I'm really proud of all the work that's done. And Aspen has been working very closely, outside the four walls of the organization. That's really what we need to do. We're working closely with A&D, ASHP, American Society of Health System Pharmacists, ISMP, we partner with as well, and looking for other opportunities. Again, trying to get the information out there. We all know that nutrition is certainly not being taught in medical schools and schools of pharmacy and schools of nursing. There are a lot of gaps out there, and we're certainly seeing those in practice as well. And what I'll be sharing with you today is really some more practical things that are out there, also some things from ISMP I think that you'll find interesting. So those are my disclosures. So we'll be talking about looking at from a practical standpoint, PN, and why is this important? It's because we're not really getting this in schools of pharmacy, right? And so we've got students and residents graduating and not really having any background, if any, very little background in parenteral nutrition, but yet they're somewhat charged in overseeing that. And so just things like compatibility and stability. And we have a residency program in our hospital, and I'm always amazed that the residents don't always understand this. And so I think, trying again to educate outside of Aspen is really important. I also want to discuss with you the recent ISMP survey, Institute for Safe Medication Practices, that was done. Anybody do the survey, by the way? Did you anybody see this? So I'll go into more detail, but we really found some interesting things from this. And based on this, we're probably going to be looking at maybe doing even more with multi-chamber bags down the road. We know that they're being utilized more and more. And I'll close by looking at some of the USP 797, the revised chapter, and some of the concerns that we've seen out there related to parental nutrition. So I wanted to start with this. There was actually a PN Summit done several years ago, International PN Summit, so I was part of that. And so that's where this slide comes from. And we were really taking the PN process that was published by Joe Bellotta in 2012 and built off that. So you can see here that process starts out with assessment, whether it's a nutrition support service or a dietitian, moves over to prescribing. And that area has really changed a lot. When I started practice in 1984, primarily saw physicians prescribing, and now we're seeing dietitians and pharmacists and nurse practitioners and PAs taking more of that role. So that definitely has changed over the years. And so then we move down to order review verification, which really involves the pharmacy, right? And so that's a very important step. And that generally is the pharmacist then moves over to compounding, which could be the pharmacist or the pharmacy technician. Then administration, obviously in the hospital, that's a nurse. In the home, that's a caregiver of the patient itself. Then in the monitoring stage, and we go back to reassessment. So what you're looking at here is some projected error rates, just looking at various, so I'm going to put my glasses on. Give me just a minute because I don't want to misspeak here. But just looking at, assessment and reassessment, some potential errors here, really is the PN really indicated? Is it appropriate? Actually Aspen has a paper regarding parental nutrition appropriateness. Then you look over to care transitions, which really is kind of tails off this circle, if you will. So it's actually been reported in one publication, an error rate of 46%. Who believes that? I do. Because as I transition patients, I see errors occur. And it's really a lack of communication. We had this conversation last night, had an opportunity to have dinner with Adina and Allison. We were talking about some of this transition of care and where we're really kind of dropping the ball. And it really is a lack of communication. Then we move over to prescribing. And so this could be, doses outside of normal ranges, incompatibilities, and, that really has to start there. So the error rate is actually reported up to 8% in that particular area of the PN process. Then order review verification. So, where you're lacking information, could be some errors there in terms of misinterpretation. Error rate as high as 39% in this particular area has been reported in the literature. And again, this is typically done by pharmacists. And, I know when you look at this from a competency standpoint, many health systems and hospitals really have not spent a lot of time in this particular area for competency. I know even in my own facility, we still have a nutrition support service. We'll write the PN and, we can all make errors, or we now obviously do it through the EHR, but sometimes things are missed by order review. And so I think we need to spend more time there, in my facility and others as well, looking at verification, order review. Then we move over to compounding. Obviously, a ton of opportunities here for errors to occur. Product mix-up has been reported in the literature. Sterility, stability, things like that, as high as 42% in terms of the error rate here. Then administration. I can tell you in my facility, this is where most of our PN errors occur, in administrative area of the PN process. And so reported up as high as 35% here. So I always like to ask, do you look at PN errors in your hospitals? And we can just raise hands if you do. I'd love to know that, right? So when we did our gap analysis back in 2012, only about 44% of the institutions said they were actually following or were reporting PN errors. And so we've just done a PN gap analysis. And so we're looking at some of that data right now. So I think we made some improvement in that area. That's also why we really teamed up with ISMP. So when you look at ISMP and medication error reporting, they're really the gold standard. So they've been around for 30 years and they're interested. So I think we're going to have a great partnership with them. But we really have got to be sure that we're reporting these errors. That's how we learn. So when we're looking at talking to people like USP, ISMP, they always want to know about errors, right? And so if we're not reporting these errors, then they're like, well, there's none reported. So say, for instance, with USP, why do we need maybe a PN chapter? So things like that are really important when you're trying to move the needle, if you will. And then lastly, this reassessment does occur, and it should occur after monitoring. So really part of the PN process, but you can see a lot of opportunities for errors to occur in all these. So how many people are familiar with this paper? So this was published back in 2024. So especially for the pharmacists in the room, but honestly, anybody in the room, you should really should have this in your files. And it should be required reading for all pharmacy students. I'll be honest with you, because I think that, we're not teaching this in schools of pharmacy anymore. This does a nice job of taking the data and the studies that are out there, and they use the word distill. So being a Southern boy, that caught my attention. I love the word distill. But it does make sense, right? You're taking this, you're taking all this information out there, you're trying to distill it down, you're trying to maybe, enhance it, but maybe just pare it down a little bit so more people understand what's going on. So, because some of these studies get a little bit complex and complicated. And, in pharmacy, oftentimes we have many roles, so it may not be PN and maybe some other things we're doing as well. But this particular article also really works through the PN process and how it relates to compatibility and stability from prescribing, order review, compounding, and administration. So I'll give you an example. The calcium phosphate, right? We're all familiar with that. So it talks about the importance of that being, part of the prescribing process, and then also being enhanced by the order review, being sure we catch that if there's some issues there by the pharmacist when they're doing order review, and of course the importance of compounding. The sequence of this is really important. How are we adding the components to the PN? Are we doing it right? Or because we don't, we enhance or we increase the opportunity for that precipitant to form. And then over in administration and filtering. Filtering is really important. So the good thing is, and I can't share all the new gap analysis, but one thing we did find in the gap analysis, about 73% of the people reported they were filtering PN. So that's an improvement. So I do think that in some areas we are moving the needles. That's fine. So again, if you don't have this paper, I would encourage you to get it. If you have students and residents, I would encourage them also to read it. So some of the things that this paper outlines is definitions. And, I found with my pharmacy students and pharmacy residents especially, they don't really understand some of the definition. Things like compatibility. You mentioned the word compatibility, and they may or may not really get that. So you always think about a relationship, right? Is your relationship, are you in a compatible relationship or not, right? And so you're looking at physical and chemical coexistence here. So my wife and I have coexist for 41 years, by the way. So I feel pretty good about that. I don't know how she's put up with me for 41 years, but she has. So it says two or more components. So most definitely here. And so you're looking at combining these, and are they compatible? And, when you're looking at a PN, you're looking at 40 or 50 components when you start including all the amino acids and all. So definitely important. And then we talk about incompatibility. So this is interaction between those substances that it can be an active ingredient, maybe excipient in that ingredient as well. So, a binder or something like that, if you will. So that can be either physical in nature. So it could be complexing, that could be an incompatibility, or it could be chemical, where there's an interaction here, or maybe some ions that would also be considered incompatible. So looking here, you might see something like a change in color, change in the pH of viscosity, yielding of a precipitant. We always think about that with PN. So that would be considered incompatibility. And there are certainly consequences here, right? So maybe lessens the effectiveness of the PN or the product that you're administering, or it may even lead to toxicity. So incompatibility is really important. So understanding the difference there is really important. I do think we kind of dropped the ball there in schools of pharmacy. Stability. So again, oftentimes people think about stability and sterility being the same. They're not. So you're looking at the integrity or the chemical integrity of the product here. Really important in PN, right? So we know they're not stable. We're going to talk a little bit about this deeper into the presentation, but you're looking at over time, what's that product? Is that product stable? Is that product safe to give? So things that can be unstable in terms of a product or instability, the active ingredient itself, the combining all these products may be instability. It can be physical in nature. So maybe a crystallization is given an example here. Chemical oxidation. Some components can certainly be oxidized, especially when exposed to light. So this instability can certainly also enhance that risk of precipitant being formed, can maybe be visible, maybe not. You can't always see those things, but also, I think that the key is, looking at appropriate stability indicating methodology is really important in this area too. So these products can degrade over time, can be harmful to the patient. So that stability factor is really important when you're looking at a complex medication like PN. So this is an old slide I've had for years and years, and many of you have probably seen this. You're talking about cracked versus creamy versus marbled. And so at the very Bottom there, that's really an overstatement of calcium phosphate precipitate. So if you don't see that, you probably need to get your eyes checked. Okay, so that's just a huge overstatement there. But you start seeing things like that. You walk into the patient's room, or this happens in the home environment. And this is really where the home environment is really a key here, right? Because we're sending out numerous bags to these patients. So we need to be sure that they're stable. So we start seeing things like this, it's concerning. You've got a stability issue occurring. Mixing sequence, that's also defined in here. So again, it's important that the proper mixing sequence with PN be followed, right? Because if we don't do this correctly, it enhances that possibility of an unstable PN formulation. Calcium phosphate, again, always comes to mind too. And beyond use days. So it's always some confusion here. So this is really the date and time by which the PN infusion must be started at the latest. So there's some confusion when you look at some of the revised USP 797, which really is based on BUD. But that BUD from 797 is all sterility. We'll talk a little bit more later on about how that's become confusing for a lot of people. So in terms of Aspen, for the BUD for us, we say 30 hours at room temperature. And I think that encompasses most of the PNs that you're going to be using in practice. So what I also like about this particular article is it goes into gives you some examples of where there might be some TPN instability, and you want to be within these ranges here. So it also gives you specific products, and that's also an important factor too. So when you're looking at stability, one amino acid does not equal another amino acid. So you need to be looking specifically at the product. Like here, this is called out here, where you want the concentration to be. Many of you are familiar with the 4-10-2 rule, right? We talked about that last night. And so from terms of stability, we always want to follow that. Now, there's some other information out there from manufacturers that you certainly can follow if you have that information. But just in general, these are the concentrations from amino acids, dextrose, and lipids. Now here, looking at 100% soybean oil lipid is where you want to be within that concentration here. And then we move into divalent, monovalent cations. Again, very important here. Adina and Allison and I were having this conversation last night. We probably need to do some additional study here, to be quite honest. Some of this information is older, but this is what we've got. At this point, this is what we need to follow. So when you're looking at divalent cations, you can see that would be calcium and mag, gives you a range there along with monovalent. Typically, that would be sodium, potassium, and those ranges there should be followed. And phosphate at 15 millimoles per liter. These are, I think, good. It's a good example, a good guide, if you will, when you're looking at writing PN, if you're involved in that as well, especially if you're involved in training. I think this is an excellent source to go to. It also gives you another example. So here you're looking at another amino acid product and another lipid. So you can see some difference here. So this is why I say you'd want to contact the manufacturer in terms of stability, because it is different, right? One lipid emulsion does not equal another lipid emulsion. So we know that in practice. So some difference here is outlined here is calcium, mag, sodium, potassium, and phosphate. Ranges given there as well. Like I said earlier, we need to do some more work in this area, but this is what we have, and this is really what we need to be going by. Now, and I think, when you have students and residents, my pharmacy residents, they really struggle with the electrolytes. That's the hardest thing for them to really grasp. So I use this as a guide for them. I think it's helped, having that in front of them and having this as a resource. So again, if you don't have this, I would encourage you to get it. It also goes into how you actually the order of mixing here. So you can see it's amino acids, dextrose, any sterile water, phosphate, electrolytes there, trace elements, vitamins, and calcium gluconate. So if we're looking at 3-in-1, we definitely need to be using calcium gluconate, especially with inorganic phosphates that we're using. And lastly, lipid injectable emulsion. So we know that if this sequence is not followed, it certainly increases the risk of instability. So you never want to add lipids to the dextrose, for instance. And so, if you have an ACD, it should be actually programmed to do this, but we still have people who manually compound parenteral nutrition. So this guidance should be followed as well. That's something that's taught in pharmacy schools. So that's why I said, I think this really needs to be required reading, that you just have a general idea of what you need to do. And one thing I find with pharmacy students and pharmacy residents, they sometimes say, well, this is a technician's job. Wouldn't disagree. Most places utilize a technician, but the oversight's by the pharmacist, right? So you have to have an understanding of this truly, so you can be sure that everything's being done appropriately and no patient harm occurs. They wrap up here with things, key points here like compatibility and stability. Those are very important along with sterility. So think of those three things. When you think about parental nutrition, compatibility, stability, sterility, looking at how you're prescribing PN in your facility. Again, looking at the products that you're using, also from a stability standpoint, very important as well. What about shortages? Anybody had any shortages, right? And what are you going to do with those, right? And it's amazing. It's still occurring. Every day I go in, it's something we're short of. It just doesn't seem to stop. I mean, it's one thing after another. I don't know. I wish I could say more about that, but it's at this point, you think we'd have a better handle. So it's not just PNs, obviously, it's other medications as well. And so this is where we've seen a lot of errors occur too, this time of PN shortages, where people maybe substituted a product that was not being used in the institution. They may be substituted for the home environment, and it causes an issue in terms of precipitation, things like that. Calcium phosphate solubility, very important. If you have an EHR, you oftentimes see these curves, but look at the curves. Depends on, what you have. I mean, I looked at the EHR the other day that someone showed me, and their calcium phosphate solubility curves were based on 4.25% amino acid, 25% dextrose. Do we do that a lot anymore? No, right? So when I started back in the 80s in hospital practice, that's what we did. We had a 50% dextrose bottle and an 8.5% amino acid bottle and dumped them together. Thought we knew what we were doing. We probably didn't, right? But that's all we knew at the time. So issues like this are really important. And so you need to not only rely on those stability curves, but other data you see, and be sure that your EHR is really reflective of what you're using in terms of PN in your patients. And all these compatibility, stability issues, certainly are, if we're following these, definitely prevents the mortality and morbidity that certainly can occur with parental nutrition. Again, it can be a harmful product, very helpful to a lot of patients, life-sustaining for so many patients, but it can be harmful if used inappropriately. So that's really just the gist of that I wanted to show you. There's a lot more in there. I don't have time to show you all the tables. I just picked out a few of them. So again, if you don't have this, I would encourage you to get that particular article. So I wanted to just touch base a little bit on ISMP and ISMP survey. So this was done between December 2024 and January 2025. Now, the respondent numbers were not huge, only 280 respondents. And you'll note here that most of them were pharmacists. And people always ask why. Well, ISMP, you're looking at primarily sending surveys and newsletters to medication safety officers, right? So those are usually are going to be in the pharmacy department or connected with the pharmacy department. So you do want to look at that with a critical eye. This is primarily pharmacists. But the interesting thing in our new gap analysis, it really flipped from 2012 to the new gap analysis. So most of our respondents in this gap analysis are dietitians. So it's going to be interesting to see, when that data is all compiled, how that looks. So I did want to share this with you because I think there's some good learning points that we're going to really take these from ISMP and move forward with. And so, if you're not familiar with ISMP, they've been around for 30 years and they've done really an excellent job. And now are starting to help us a lot with parental nutrition. Rita Jew, if you were at Aspen a few years ago when I was president, she actually was keynote speaker. So she's been very helpful, a pharmacist with a neonatal background who's been involved in parental nutrition. So she really does understand some of these concepts that we're talking about. So as I said here, most of these respondents were pharmacists here. Hospital size, majority of them were anywhere between 100 beds and over 500 beds. So my hospital would fit in that 300 to 499 bed range, so about 25% of those. So you can see most of those hospitals are larger in size, and some of the smaller hospitals, probably don't need to be involved with parental nutrition, to be quite honest. So it doesn't make sense. In our facility, we're part of a 28 hospital system. We do have a lot of critical access hospitals. They don't really do a lot of PN. So we only have really about 10 of our 28 that do PN. So in the settings, 87% of these are from the hospitals were United States based, and you can see majority of them were either community or teaching. I will say with this new gap analysis, more of those that answered were teaching hospitals, but primarily that's where most of the data came from, and then there's kind of a scattering there of the other sites in terms of who answered the survey. Multi-chamber bag. So I really had an interest here because I suspect that we're using more of these, and I really believe that we are. And so I just want to show of hands, who's using multi-chamber bags in their facility? Anybody in the room? Everybody compounding? That's impressive. That's good. Okay. Well, let's shot that then, huh? Okay, no, just joking. I do think that we're probably going to start seeing these utilized more and more. And so within this particular survey, we noted that 53% said they were using multi-chamber bags in their practice. 26% said they use them for all their PN patients. And so we are starting to see an increase of these. And again, 34% said they used it less than 25%. And 34% had stated they had increased the use because of drug shortages over the last 3 years. And that would make sense as well. And so, we've had to do that in our facility. You're also seeing a lot of people do kind of a hybrid, if you will. They use some multi-chamber bags and they also compound. So sometimes if they can meet the needs with a multi-chamber bag, they'll use that. If not, then they'll compound. So a hybrid model is also out there as well. So again, as I suspected, I think we're seeing more use of these. I will say, we have at Aspen really preached, if you will, to use the term multi-chamber bag and not pre-mixed. Pre-mixed was one of the older terms. And you still see it in the literature. So if you do a search, you're probably going to see pre-mixed parenteral nutrition. But again, it's not really pre-mixed, right? It's got to be activated. There are other components that need to be added. So that pre-mixed term really needs to go away. So we really honed in on that and tried to work with other organizations as well to help us with that. So this is a topic that came up actually in our clinical work group a couple of weeks ago. So I saw on the agenda that they had multi-chamber bags. I'm like, well, this will be interesting because we're really the only hospital that has a nutrition support team. None of the others have a team. So I was like, know where this is going to go. So the discussion was what we really need to do is put these in the automated dispensing cabinets on the floor and create labeling so the nurses know how to activate. And I'm like, time out. No, no. And, and a couple of people spoke up and said, well, that just makes them readily available. I'm like, it's not a stat drug, guys. It's not a fluid. It's okay. You need to have standard hang times and things like that. So in this survey, you did see that 91% of them said they'd stored or dispensed from pharmacy. And then there were some combinations listed there as well. So, at least they were down in pharmacy. But again, some concerns do arise. And we'll look at some of those. So who's activating these? Like I mentioned just a minute ago, Aspen and even ISMP now is on board. These should be activated in pharmacy under sterile conditions, aseptic technique, adding vitamins, trace elements, and being sure if you're using a 2-chamber bag that you are providing lipid emulsions as well. Really important. So in the survey, 50% said it was most often activated in pharmacy in a sterile environment, but not always. So okay, so what does that mean, right? So that's pretty inconsistent and leads it really to potential for error here. There was 11% combination kind of nursing and pharmacy. 11% said it was always activated by nursing. So if it's activated by nursing on the floor, there have been reports where that doesn't happen because it's not clear. They don't understand. Obviously, you look at nursing nowadays, they've got 5 or 6 patients. It's a lot going on. They're having to do a lot, so they really don't need to be activating these. And then, if they're activating, are they doing additives? Probably not. But very concerning there when you see, where these products are being activated. The question was asked, and this is adding to the multi-chamber bag, by the way. So it was good to see that 83% said they were adding multivitamins, 73% said they were adding trace. So that's good. I was a little surprised by that because I suspected that number would not be that high. 42% said they were adding electrolytes. Somewhat concerning if you have an electrolyte containing formulation, right? Because these products have calcium chloride, not calcium gluconate. So if you start adding, divalent cations, you may run into a problem in terms of precipitants and instability. So were these, and we don't know if these were products that didn't contain electrolytes or they were adding electrolytes to already electrolyte containing products. So again, that is a little bit of a concern. You can see 30% say they were adding some medications like insulin, heparin. 15% said they were adding lipid emulsion to the MCB for a 2-chamber bag. So, we do have a 2-chamber, we have a 3-chamber bag as well. And then we get into things like dextrose and amino acids. And, so you do start affecting the pH there at that point. And so how stable, is that? So some concerning practices going on with multi-chamber bags, at least through this survey. Now, multi-chamber bag PN errors, they looked at this as well. And so almost 30% said they experienced or were aware of some close call or error that occurred in their facility with a multi-chamber bag. So more than 40 errors were described in this particular newsletter. This is a 2-part newsletter, by the way. So there was part of it March 13th and the other was a couple weeks later. So the one that was probably the most prominent or prevalent in here was that it was infused beyond 24 hours. So in other words, these often comes in various volumes, right? And so they were letting these PN bags hang for over 24 hours, sometimes 48 hours in a few patients. So again, not a safe practice, increases the risk for infection. So those things are happening as well. So some other errors that were reported, just to let you know, the bag wasn't activated. So this is one probably it's on the nursing unit, didn't get activated. Wrong product was utilized. So they prescribed for one product and another product was used. There was one case where they added a Lispro insulin rather than regular insulin to a multi-chamber bag. And then again, another report where the order was for 10 units of insulin. The patient received 100 units of insulin in a multi-chamber bag. So concerning practices, again, things that, but again, it's good that we're reporting these errors. That helps when you look at developing safe practice guidelines. So we'll use this data, we'll use our new gap analysis and looking at what we need to do from a guidelines and recommendation standpoint. Some of those papers will hopefully be revised based on some of this data. Now, this is the one that is very concerning to me. When you look at multi-chamber bag PN competency, 68% indicate their organization does not provide initial or annual competency in any of these areas for PN. I remember when back in 2014 when we published the Aspen consensus recommendations, we mentioned a lot about competency in that paper. And so we started getting comments about, okay, can you help us with this competency thing? Because we need to develop some. So we did in all these areas, whether it's prescribing, dispensing, or compounding, if you will, administrations. They're all competency papers out there from Aspen that have checklists. So if you've not seen those and not utilized those, I would suggest you do, but I really do think this needs to be part. If you're in your facility, if you're doing PN, multi-chamber, or you're compounding, there needs to be some competency assessments done. So this is very eye-opening and concerning to see that almost 70% said they don't have anything in terms of annual competency. Again, can certainly lead to potential errors and things not being caught. So they also looked at custom PN here. So 78% indicated the organization did provide custom PNs, and 49% those compounded those on site, 35% outsourced. That's an area we've seen grow over the last few years for, well, sure. 49% said that their ACD does interface with their EHR. That's good. It's a little low. I would say on the gap analysis that we just completed, that number looks a little bit higher. So that was encouraging because that was one of the recommendations that we had. So I think we have made a little bit of progress there. So about 48% were aware that they had some type of process in place when they were going to convert a multi-chamber bag to a custom PN for a patient going home. Again, so I think that we also need to be looking at this in our facilities as well, so everybody's on the same page, because it gets a little confusing for some people. Now, some of the EHRs can outline in amounts per day and some don't. So I think, being able to do that, and again, it goes back to communicating, right, to that, in that transition of care to the next level, being sure everybody's on the same page. So, not quite there with that process. So errors with custom PN, 40% said they experienced or were aware of some close call or error, and over 80 errors were described, reported here. So a lot of these were, guess what, transcriptions errors. So when the EHR didn't talk to the ACD, the pharmacist made an error in transcription. So that's why we are very, in tune, and certainly want to be sure that we emphasize that EHR should be communicating with the ACD. Helps with that transcription error. So that was a big one. Wrong product was another one utilized. Again, insulin errors. Wrong type of insulin placed in the bag, insulin dosing incorrect. So things like that were common errors that occurred here, even with the custom PN. So a lot of opportunities, like the first slide, for errors to occur. But I think we can take some of this data, we can learn from it. And the encouraging thing is, it looks like ISMP is looking at maybe doing more of an MCB PN, multi-chamber bag PN summit, because we're seeing increased use across the country. And I think that would be good. We definitely need that. In terms of competency assessment here, not much better. 53% indicated the organization does not provide initial and/or annual competency in all those areas of the PN process. And one thing that's always been recommended is having a standard cutoff time in terms of when you compound these. So 80% said they did have a standard cutoff time, but only about 58% said they usually adhered to it. So again, kind of all over the place. So really need to be doing this when you have most of your staff there that certainly are competent and trained in this area. So it's not happening on a consistent basis, at least per this survey. So based on some of the things the ISMP saw, they did have some safe practice recommendations. So this comes into the March 27th newsletter. So you have a 13th, March 13th newsletter and 27th, which really takes the survey and makes some recommendations. So for all of us, we need to be looking at our PN process. So we probably need it at times to, conduct this failure mode and effect analysis, looking at things like labeling and how our PNs are ordered in the HR, how they're displayed on the MAR. Interesting case the other day, we got a transfer in from a patient from another facility, and they said patient's on PN, and they sent the MAR like, great, that'd be very helpful. So you know what the MAR had? Had the product name of a multi-chamber bag, didn't have a strength, and it said it's 75 mils an hour. So that's all I knew. They were getting a multi-chamber bag at 75 mils an hour. That was the MAR, by the way. So those things are happening out there in practice, very concerning. Again, the multi-chamber bag activation in pharmacy is part of the recommendations here. Standard cutoff times, again, need to do this when you're looking at your staffing. Again, sometimes I know this is problematic in neonatal. We do have starter bags that often people are using here. So when you're looking at transmitting these orders or outsourcing, that should occur in the day shift, generally when you have most of your specialists or your experts and PN there would certainly be the best practice. And oftentimes, and I've found this in numerous hospitals where I go, pharmacy is not always aware of all the PN patients. So, maybe that service is being run by the dietitians and the pharmacist doesn't always know. So, again, that's on pharmacy needs to make the effort to know all their PN patients that are in the hospital. Again, it's just safe practice. In terms of preventing these transcription errors, again, we talked about the ACD interfacing with the EHR. If no interface, recommend independent double check. And I know that people don't like to see that because how many times we're going to double check? And you can't have too many medications. I would agree that you're double checking. But I think when you're looking at high alert medications like PN, things like insulin and all, I think it's really important that we have that double check in place. And that's something that we do in our facility. And it's been very helpful. We've been able to catch some of those errors. So from time to time, too, you need to evaluate your system functionality when you're looking at your EHR. Does it pick up those drug-drug interactions, the duplicate therapy? Can you cycle PN, which has really been problematic for a lot of EHRs? Central versus peripheral. So one of the errors that was reported with a multi-chamber bag, on a couple of occasions, the patients got a multi-chamber bag that was formulated for central administration peripherally. Okay, so things like that. So you need to be looking at that within your own systems. Talking about effective verification processes in the pharmacy, again, competency certainly needs to be a part of that. Pharmacists need to be part of this at all. Sometimes that's remote, and that's okay. We just need to be sure competency is in place. Looking at the ACD and verification of products and replacement of solutions, especially in times of product shortages. This is where we've seen errors occur. And then workflow management, barcode scanning, we do have that ability now, so we definitely need to utilize that as a safety tool. Looking at stability data, like I said, amino acids and lipids do not equal one another. So be sure you're looking at those things and be sure you get the information from your manufacturer. And look when you're looking at stability data, should be readily available to everybody. So Aspen, in terms of stability for a 3-in-1, does go back to 30 hours at room temperature and 9 days refrigerated, unless you have some specific extended data that will allow you to go past that. And sometimes that data is available for various products. Hang time should not exceed 24 hours. Again, this is becoming more problematic with the multi-chamber bags because people may not get the entire volume. And so you see them sometimes hang over 24 hours. We do utilize multi-chamber bags in our facility. And so a couple of times I've gone in and the patients have been irate. They said, look, I paid for the whole bag. I want it, right? They took it. I'm like, well, I don't think you want an infection. So you just have to, it's education, right? They don't know. I mean, I get it. I'd probably say the same thing too if I didn't know better, right? So if we use the separate lipid emulsions as well, the hang time there should be 12 hours. That's a CDC recommendation along with Aspen. Storage of MCB, safety, be sure you have separate policies and procedures regarding that. And I've said it numerous times, pharmacy activation and compounding. This has got to happen with multi-chamber bags. I mean, it's really, we cannot have these in dispensing cabinets on the floors. again, more and more errors are occurring, more and more reports of them not being activated. So it needs to be, pharmacy really needs to take ownership to this, to be quite honest. Any auxiliary labels that you think are important, and again, using barcoding technology. I mean, I'll be honest with you, we still have an auxiliary label that we put on our PN. It says TPN because we had a patient that actually, the nurse said she didn't really know the difference between enteral and TPN. So we still use that auxiliary label. And that happened years ago, but we still use it. So just a safety thing for us. Using a 1.2 micron filter, looking at the newer data, like I said earlier, it looks like about 73% of the people are doing this. That's good. So one report where we started looking at the filtration of PN that we got through Aspen was that people were reporting that committees within the hospitals were not allowing them to filter or use two filters. That's back when the recommendation was a 0.22 for the amino acid dextrose and 1.2 for the lipid. And so, various committees were saying, well, that's too costly. We're not going to filter. Like, oh my gosh. I mean, not that costly. So that's why you saw the new recommendation, right, where we're using a 1.2 micron, even if you're piggybacking the lipids into the Y side, just be sure that 1.2 micron filter is below the Y side. So you can utilize one filter. So that's what we should be doing in practice. Reconciling medications, I mean, a nightmare in a lot of hospitals, I get that, but we're talking about our PN patients, so you should be looking at that as well. Again, communicating with the home infusion company or the other provider. Time and time again, document, communicate. I mean, I really, it's where we're dropping the ball, I think, in a lot of cases, and so we need to do a better job. I know in our facility, we certainly need to do a better job. Educate practitioners. So we do know that in schools of medicine, schools of pharmacy, schools of nursing, not a lot of PN in the curriculum, probably not going to be. And so, Aspen has tried to help with some of that in creating fundamental courses. We're working closely with ASHP, with pharmacists. We have a new program where we're taking 10 PGY2 residents. Most of those are either pediatric or critical care, and they're walking through the ASHP Aspen Nutrition Support Certification course, which is a fundamental course, but I think it's still a good course. And so that course has physicians, pharmacists, nurses, dietitians, all lecturing. It's about, I think, 19 or 20 hours, if I remember. But it does give them some fundamental overview of parenteral nutrition, and a good place to start. So we've seen some good interest there, and we've seen some of those. They're also not only working through that certificate program, but they also have nutrition projects too that they're working on. So that's been helpful. The certificate program, I think, it's also not only for pharmacists, but for, I believe, physicians and nursing as well. So that's been another thing that we've been working on. I think that another area there where we certainly need to, whoa, I don't know, y'all don't want to look at me, so not really sure what to do with that, okay? I'm gonna step out with Ashley. But another area that I think that we certainly need to do a better job of, and maybe we've even reached out to the Society of Hospital Medicine, so that's your hospitalist, because some of those do have oversight of parenteral nutrition in our hospital, so we're working with that group as well. I don't think I hit anything. Y'all just trying to cut me off? Was that? I can stop. So while we're waiting, any questions I can take in the interim? I'm almost finished. I'm going to go a little bit over to USB 797.
Could you go to the microphone too? So, sorry, yep, yeah, the microphones are on the side there, so the folks on the talking.
Audience, we're got to wait.
Hello. Okay, now I can hear you. Okay, earlier you were talking about errors of placing NCBs, and I had a question. What exactly are the implications of placing a central formulated MCB peripherally?
Certainly, peripherally, you don't want to see that 900 milliosmol, so some vascular damage can definitely occur there. Extravasation would also be an issue that you would worry with, which can be very problematic and can lead to some necrosis of the tissue.
Awesome. Awesome. Thank you.
Can you hear me? So I work in the home infusion sector, and when we're looking at things like Georgia Medicaid, it's much easier to bill with a multi-chamber bag PN, but we're looking at that and possibly but I want to reemphasize that the stability guidelines, you have to know what they are when you're adding and how many times you can go in the bag. And this just came up this week at our institution, or company. But you really have to, still evaluate the calcium phos curves if you're adding. And,
Situations where we've seen precipitous form because people didn't realize it's calcium chloride, it's not
Yeah.
calcium gluconate, but that can get you in trouble. So that's a great point. But sometimes you have to address those electrolyte having outside and PN, not that easy sometimes in the home environment.
right.
So that's what you have to, that's how you have to approach that.
Right.
Especially from a reimbursement standpoint. I've been there,
Mhm.
I've served as a consultant for fusion companies in the Jackson area, and we've run across that as well. So we have to try to utilize as best we could a multi-chamber bag, but I also had to do some boluses of various electrolytes because I just adding additional electrolytes.
Right.
We're trying to use an electrolyte formulation
Mm-hmm.
because of that we could do.
And it's certainly, may not apply to, may not be, the multi-chamber bag may not be indicated for every patient, just depending on the complexity, the acuity, obviously. So, thank you.
Okay, so I wanted to end looking at USP chapter 797. Going back to the 2008 USP 797. So if you remember. Thank you. So if you remember, there were different risk categories. So you had a low risk, a medium risk, and a high risk. And so parenteral nutrition fit in that medium risk level category, if you will. And so it was very clear where PN fell. And so clinicians knew that they had, 30 hours at room temperature, refrigerated for 9 days. Again, in the home environment, there are additives like MVI you have to do, but for the most part, 9 days. And so you could send out generally, 7 bags, 7-day supply or 7 bags for the patient. Within the chapter, Seth, this is straight from the chapter. It talks about the compounding of total parenteral nutrition. They do fall under 797. Medium risk. Didn't matter if you were using an automated device or you were doing this manually. So it was very clear in that chapter where PN fell. And that fell within the Aspen parental nutrition guidelines as well. And so again, that 30 hours at room temperature, 9 days refrigerated, followed by 24 at room temperature. Again, not to hang over 24 hours. So here's where the confusion comes in. So the revised USP chapter published a couple of years ago moved from risk levels, I should say, 2 categories. So category 1, 2, and 3, and did not specifically state what category parenteral nutrition would fall in. So looking at, and then what you're seeing on the slide here is category 2. And I've circled here that it's prepared only from sterile starting components. So most people were putting or are putting parenteral nutrition in category 2. But under there, you see at controlled room temperature, 4 days. So that was being interpreted by some people that if you were compounding PN, that you had 4 days at room temperature. Very confusing, right? And so for those of us in the PN world, we knew this was not correct. And I was actually moved over to this chapter, but it had already been published by the time, pretty much published. It was in rough draft. So I tried to intervene as best I could. So this is really all they would do. They said a shorter BUD must be assigned when the physical and chemical stability of the CSP, compounded sterile product, is less than the BUD stated. So that's where your PN would fall in, right? So we know the BUD for a PN is not 4 days. So the concerning thing is I was doing a presentation at ASHP, American Society of Health System Pharmacists, and had a few pharmacists come up afterwards. And they said, well, you pointed that out, but we were kind of told 4 days because we were interpreted as category 2. I said, okay, here's the deal. All these tables are based on sterility, not stability and compatibility. So you got to keep that in mind as well. So that's why the footnote is there. So when you see this, and if you're challenged, yeah, 4 days of room temperature, that's only sterility. And we know we're dealing with a complex admixture here. So keep that in mind as well. So just some key takeaways here. I know I'm running out of time, but we talked a little bit about the importance of compatibility and stability. Again, something that's not necessarily being taught, especially in schools of pharmacy. So I refer back to the article. I think it's a great overview. Talked about the ISMP and their involvement in PN safety. They're continuing to help us there. And I think will help us move the needle, if you will. And I just closed talking about some of the recent USP Chapter 797. And ideally, hopefully, and Adina kind of called me out last night, which is good. She said, where are you on this USP PN safety chapter? I'm like, oh, okay. I'm like, well, I'm trying. Okay. It's been a challenge, but I understand, they run in 5-year cycles with USP. So hopefully this next 5-year cycle, they're going to be looking at that. And if you see a call to action where maybe being on a PN safety task force with USP, I would encourage you to apply. Okay. They need everybody. They need every discipline involved in PN on those task force. And that task force would create like a stimuli article, which may lead to a chapter. So it's a long, drawn out process. But if you see that call, and if you have the time, please take advantage of this. So just some quick self-assessment questions. Studies have shown the PN transition of care error percentage to be. Look at this, smart audience. Recent ISMP survey indicated what percentage of organizations utilize MCB PN? 53, very good. According to the revised USP Chapter 797, PN is stable for 4 days of room temperature. I wanted to put something else, not no, but I couldn't do that, right? So that would be false. So there's references, and I believe the slides will be available to you. So I know we maybe have just a few minutes for questions to stay on time here, but unfortunately, I can't stay the day with you. I've got to get back to Jackson, but I will be available for any questions that you have afterwards, or I can take maybe 1 or 2 before our next speaker. I don't want to run into their time, but I do want to thank you for your time and attention. I hope you found this helpful. They all have my contact, so if you have questions, please just reach out. I'm happy to help in any way. And again, thank you for all you're doing for the patients and for PN safety, and for your interest in not only Gaspin, but Aspen as well. So thank you again. I appreciate the opportunity.
Well, for the people online. Oh, sorry.
Yeah, I tend to step away from the mic myself, so I got to come back over here.
Thanks for the presentation. It was great. And these are 2 questions based upon on the periphery of what you asked. One is when she asked the question about peripheral, you said 900. So my question is, why do some institutions allow 3% normal saline in an IV, and its osmolality is greater than 900, and they allow it for several days? So why can't peripheral follow those guidelines as a short period of time? That's question 1.
Yeah, I think that's a good question. I will say that I know in our hospital, we may allow that for a short period of time, for less than 24 hours, and we require a central line. I still believe at 3% saline, it's the safest thing for the patient, that you have central access, especially over extended period of time. Maybe in the ED for, a few hours, you're fine peripherally, but once you extend it out, you're really putting the patient at risk, and some harm can certainly occur. So that would be, that's my concern, and kind of why we really required our medical staff to place a central line, if they're going to be past 24 hours on a 3% saline.
Okay, and then the second question is you talk, excuse me, how this changes every 5 years and the importance of that. And then why do we still have guidelines that are like 10, 15 years old that we are supposed to still be following?
Yeah, and another great question. One thing, when you look at guidelines, and of course, Aspen has also changed how they do guidelines, trying to use the grade process. And nutrition doesn't fit that great in the grade process because we have limited studies and they're small in number. So that's a little bit of a challenge. So not a lot has changed necessarily in some of these areas as well when you look at PN safety. But looking at some of these gap analysis that we're doing, not only with ISMP, but Aspen, we're going to be able to collect some additional data. We will know at that point what we're doing well, what we're not doing well. You know, for instance, I was really curious to see how many people were ordering in amounts per day or amounts per kilogram per day with PN. You know, did we move the needle there at all with the consensus recommendations? And hadn't looked at all that data yet, so I really can't state at this point. But some of it it's really just a lack of newer publications is why. And then, you know, assessing where our gaps are also help us create new recommendations and guidelines. And so will we be able to publish new guidelines in the grade? I don't know. I mean, when you look at the latest guidelines that were critical care, they were quite a struggle when you look at critical care and nutrition, right? Because the studies were so small and honestly not great. Some of those studies were poor. And so you end up with like weak recommendations. And so that's another thing that sometimes people don't understand. I'm a pharmacist, so when I look at studies, they sometimes have thousands of patients. I'm looking at a nutrition study with 40 patients. So that limits us as well in terms of what we can do. Well, great questions, by the way. All right, I think I'll stop there. I know we've got another speaker behind me, so thank you all. I appreciate it.